defined as inflammation of the vessel's wall. There are many mechanisms like immune complex deposition, anti-neutrophilic antibody-related vasculitis, anti-endothelial antibody-related vasculitis, and autoreactive T-cell mediated vasculitis. So basic mechanism of vasculitis is related to the immune complex mechanisms, and most of them are chronic relapsing inflammatory disease involving the vessel walls and causing destruction. We are going to cover each one mechanism one by one. First one was immune complex mediated vasculitis. In this, immune complex deposition occurs. We can rarely identify the specific agent, and this immune complex deposition assays, when we do, have got low sensitivity. Antigen antibody complex may be scarce, maybe because of degradation, and we can also call that post-immune vasculitis. For example, the disease mentioned is SLE, systemic lupus erythematosus. In this, vasculitis can be part of the SLE syndrome. So what happens? Either you can find this immune complex deposition in the vessels, or rarely you are not able to find because the complexes are very scarce, small in quantity, or either they are degraded. So that's why it's also called post-immune sometimes. Prototype example I give you is SLE, systemic lupus erythematosus. In addition to SLE, there are certain drugs or foreign particles which act as a immune complex reaction mediators. They can act as a hapten. In cases of streptokinase, immune complex bind to the vessel wall, and hypersensitivity vasculitis can ensue. Vasculitis can also be related to the formation of secondary antibodies, because in this, in certain infections, for example, in cases of hepatitis B, a hepatitis B antigen can result in a specific type of vasculitis called which is called as PEN, which we are going to cover later on. So the immune complex can be deposition can either be primary autoimmune disorders like SLE. It can be related to the drug, or it can be related to foreign particles like microbe-related secondary antibody formation. And I gave you example of hepatitis B. The second mechanism was anti-neutrophilic cytoplasmic antibody, which is in short form is called as ANCA, anti-neutrophilic cytoplasmic antibodies. This is also immune-mediated mechanisms. Antibody react with neutrophilic cytoplasmic antigens. That is, the antigens are present within the cytoplasm of the neutrophils. These are directed against the constituents, mainly enzymes. In neutrophil granulocytes, monocytes, and endothelial cells, this can also be this reaction can also occur, but prototype is neutrophilic cytoplasmic antigen. ANCA antigens we can also detect in blood, and these are we can call them diagnostic markers, as compared to immune complex deposition, which we already discussed can be post-immune. Increased titer of ANCA antibodies in the blood will show increased severity of the disease. Increase in period after some time, normal period, will indicate the disease recurrence. So we can also monitor the relapses of the vasculitis by using ANCA antibodies, in which this ANCA antibodies are raised. Now these are previously they used to be called ANCA, now PR3 and MPO ANCA are two types of ANCA antibodies. PR3 ANCA are directed against the azurophilic granule of the neutrophil, and they share similar homology with microbial peptides. For example, in cases of polyangiitis, which is type of vasculitis seen in polyangiitis, we are going to discuss later on. So this is directed against the neutrophil granule, neutrophilic azurophilic granule. The second type of ANCA antibodies, MPO, ANCA. MPO is a lysosomal granule constituent involved in free oxygen radical generation. The MPO ANCA antibody generation can be seen in cases of when we administer the drug propylthiouracil, and in cases of microscopic polyangiitis is a type of disease, and Sharp-Strauss syndrome. These are the three types in which MPO ANCA antibodies are raised. What happens in ANCA? And neutrophil release free oxygen radicals, and proteolytic enzymes are also released, which cause destructive interaction between endothelial cell and inflammatory cells. Although targets for ANCA are located intracellularly, but low level of ANCA are expressed at the plasma membrane or translocated to the surface in activated and apoptotic leukocytes. So, basic mechanism is oxygen-derived free radicals, which also secondarily release the proteolytic enzyme, which are responsible for destruction of endothelial and interaction between the inflammatory cells. Drugs or cross-reactive microbial agents can also result in ANCA formation, which we already discussed. That's called homology. That means they look similar to normal molecules present on the surface of our cells. So in this way, they cross-react. Leukocyte surface expression of PR3 ANCA or MPO can also be seen in genetically susceptible hosts. This can also be the mechanisms. Reinfection. On reinfection, endotoxin or inflammation lead to cytokine release. For example, TNF, tumor necrotic factor alpha, upregulation of PR3 ANCA or MPO on neutrophil or other cell types. So on reinfection by these inflammation can or endotoxin release can increase the TNF factor TNF upregulation or production on the surface and resulting in PR3 ANCA or MPO ANCA increase from neutrophils or other cell types. ANCA react with those cytokines activated cells and direct inflammation, or it can lead to secondary involvement of other inflammatory cells in inflammatory cycle. Now, in this also, there is a pauci-immune vasculitis. In pauci-immune vasculitis, type of vasculitis, they do not form circulating immune complexes. So ANCA antigens can be positive in cases of disease, in which they also can be used to monitor these diseases. The prototype diseases which I have given is IBD, inflammatory bowel disease, rheumatoid arthritis, and sclerosing cholangitis. So ANCA you can use to monitor these diseases in addition to many other diseases as well. The third mechanism of vasculitis is anti-endothelial antibody formation, and fourth one is autoreactive T cells. Now, there are some hardcore or basic facts related to vasculitis. Vasculitis can affect all ages, but certain types of vasculitis are restricted to somewhat restricted to certain age group or have predilection for certain age groups. Vasculitis tend to affect Caucasian race more, and many African Americans are also affected. Vasculitis has a genetic component, but it is not inheritable like certain kind of genetic disorders. Vasculitis is a chronic relapsing disease. So we have to monitor it, and relapsing means we have to give the patients certain drugs, and then we monitor the patient. Lifelong monitoring is required. Although certain patients can respond very well and can go to experience prolonged remission. Now, vasculitis classification. first we covered the definition of vasculitis, and then we covered the pathogenesis of vasculitis, and then third aspect we covered some basic facts. Now, classification of vasculitis depends on this is one type of classification which I have given you, but you can classify on and the different aspects as well. First is large vessel vasculitis. This classification is based on the caliber of vessels, large vessels or medium vessels or small size vessels. Large vessels, as we know, are aorta and great vessels. Arteries with muscular wall, renal arteries, also medium vessel vasculitis. Small vessels included in vasculitis can be capillaries, arterioles, and venules. In large vasculitis, claudication, blindness, stroke. The sign and symptom of vasculitis also depends on the area supplied by that vessels affected and the caliber of vessels as well. Like in aorta, if this is involving blood supply to the brain or cerebral artery, stroke can result or blinding can result. In the medium vasculitis, vessel vasculitis is involving foot or wrist or mononeuritic complex formation, mesenteric ischemia, and cutaneous ulcer when involving the femoral arteries. In case of small vessels, purpura, glomerulonephritis, and pulmonary hemorrhages in the small vessels of these systems, kidney and lungs. ANCA-associated vasculitis, this is another classification. We can do classification, I told you about the calibers, and we can do about the immune complex associated, like ANCA-associated, or Wagner's granulomatosis, microscopic polyangiitis, and Churg-Strauss syndrome. Wagner's is a granulomatous inflammation involving the respiratory tract. In addition, it also involves necrotizing vasculitis of the vessels, which are small to medium size, and microscopic polyangiitis affects the small vessels. All these three are type of vasculitis, plus in addition, in this Wagner's, there's involvement of other system as well, and in Churg-Strauss syndrome, this is also involving other sign and symptoms as well, like asthma and peripheral eosinophilia. These are three types. A combination of ANCA in vasculitis. This already discussed. The necrotizing granuloma formation is seen in this three types of vasculitis, and Wagner's, MP, and Churg-Strauss, I have given you the main pathologies or sign and symptoms and systems affected. Now, vasculitis, giant cell temporal artery vasculitis. We are going to cover each vasculitis one by one. Giant cell temporal artery vasculitis. This is the vasculitis of large to medium-sized vessels seen in old age. Sites involved are temporal artery, head, ophthalmic, vertebral, aorta. Really, when involved the aorta, called giant cell aortitis. T-cell mediated immune suppression is there. ASMA, anti-endothelial antibody formation can be the mechanism behind it. What is the morphology of vasculitis of vessels in this case? There will be granulomatous inflammation, elastic lamina fragmentation, which is component of the vessel. T-cell and T-cell and macrophages will be there, and this vasculitis can be focal. That if one part of the vessel is affected, the other part can be normal. So if we do the biopsy, if that comes normal, that does not exclude the giant cell temporal vasculitis. So we have to see in that context as well. The second type is temporal arteritis. This is seen in less than 50 years. Medium to large vessel calibers are affected. So the prominent sites which are affected are aortic arches, branches, renal, aortic, and pulmonary artery. So sign and symptoms, I told you, will be depending on the area affected, area supplied by this vessel, like ocular disturbance, if this is involving ophthalmic artery, blindness, retinal hemorrhage, weak pulse in the upper extremity, decreased blood pressure, neurological deficit, myocardial infarction if it's involving the heart, aorta, main branches, systemic hypertension can be the result of this vasculitis. Pathogenesis is autoimmune mediated vasculitis. What is the morphology? Morphology is transmural fibrous thickening, mononuclear infiltration with perinuclear cuffing of inflammatory cell. Cuffing means that mononuclear inflammatory cells are surrounding the vessels in like a complete circle. There will be granulomatous inflammation as well. Here is the involvement of ophthalmic artery. This is the dilatation. So this area can easily be biopsied. Here is the histology. This is the intima, media, and outer part of the vessel will be adventitia. Here you can see hemorrhage, and all this inflammation is involving full thickness of the vessel wall. That is called transmural inflammation. There is a hemorrhage and giant cell. So giant cell temporal arteritis is the name because the giant cells are also there. And here you can see the vague histiocytic collection. The third type is pan-polyarteritis nodosa. This is involved young age, rarely seen in pediatric and geriatric population. The caliber of vessel affected are small to medium-sized muscular arteries. Muscular arteries in mainly this affects renal vessels, visceral supply of the vessels, mostly spares the pulmonary circulation. 30% of these cases are positive for hepatitis B surface antigen. So whenever we detect this disease, we can also go for this hepatitis B surface antigen profile to detect the hepatitis. We can be able to detect hepatitis association in 30% of the cases. So we have to do that as well. This here the important lies in pulmonary circulation, where it spares pulmonary circulation because certain type of vasculitis will involve the similar type of vascular vessels, but involve the pulmonary circulation. So you will base your differential diagnosis also on this scenarios. The site of involvement, anatomical distribution of involvement of the vessels. PAN is the short name of this disease. Signs and symptoms are rapidly accelerating malignant hypertension, abdominal pain, because I told you it's involved the visceral vessels, bloody stools, bleeding per rectum because of GI involvement, myalgias, muscle involvement, peripheral neurological defects, especially motor nerves. Morphology. Segmental transmural necrotizing inflammation. So this may seem like a lot of information, but try to break each one by one. Segmental I take first is part of the vessel involved, not whole of the vessel is involved. And transmural means full thickness. The part of the vessel, the length of the vessel, only part is involved, and that part is transmurally involved from intima, media, and adventitia. And that type of inflammation is necrotizing inflammation. There will be transmural necrosis of that segment. So in this way, you can break this, and even you can make the diagrams yourself. So this way you will remember easily. This has got predilection for the branching points of the vessels. Their type of necrosis is fibrinite type of necrosis, and all level of activity means inflammation, like healing, acute phase, a chronic phase of inflammation coexist in different or even within the same vessel. So you can find that in one part of the vessel there's active inflammation going on, the other part is scarred. So in this way you can find different type healed scar. So you can find a different kind of active inflammation or phases of disease in the same vessels, even in the same vessel. Next is Kawasaki's disease. This is also a vasculitis. 80% cases are seen in children. This is important to remember. 80% are in children, but certain time there are very few types of vasculitis which have predilection for children. So this is one of the type. This is for the scientist. Medium to large size vessels are involved. And especially importance lies in that the coronary vessels are involved in children. The mechanisms, or you can say pathogenesis, is T cell or macrophage mediated destruction of the inflammatory of the vessel wall. Here you see this is the lumen, acute and chronic inflammatory cell infiltrate along with necrosis of the vessel wall. Here you can see fibrinoid. Fibrin is a pinkish material. This is a case of a classic polyarthritis nodosa. And inflammation is transmural as well, all the way from intima to the adventitia. Kawasaki's has also called certain types. It's called mucocutaneous lymph node syndrome. Mucocutaneous lymph node. If I break it up in three parts, you can remember muco means mucous membranes of a conjunctiva. There will be erythematous. Cutaneous involvement like hand and feet, there will be edema, blistering, and rash. Coronary involvement, aneurysm, and even in myocardial infarction in children. Lymph node involvement, there will be lymphadenopathy. Treatment is aspirin. Morphology is similar to PAN, but like less fibrinoid necrosis in case of Kawasaki's disease. Here's a example: red eyes, dry cracked lips, and red tongue. Kawasaki disease, another diagram. Pink eye, oral mucosal change, enlarged lymph nodes, patchy rash, peeling skin. Vasculitis, microscope. Other type of vasculitis we are going on. The age group is like a middle age group, and this involves, as the name indicates, microscopic. So you can remember small vessels, arteries, and venues are affected. Sites are skin, mucous membrane, lung, brain, and again gastrointestinal tract, kidney, muscle, pulmonary. So wide level of involvement of organs. Pauci-immune. So you may not, pauci-immune means you might not be able to detect any immune complex in that. Either pauci-immune or autoantibody to certain drugs in cases of if you give penicillin, which cross-reacts in the body, or if there's an infection with or microorganisms, this produce streptokinase or any other which has similar homology, heterologous protein formation, and tumor proteins in cases of tumors as well. This can also result in microscopic polyangiitis. So we need to screen for microorganisms and take the history of drugs as well, and similarly for tumor proteins. Sign and symptoms will be based on the, as we have already discussed, then their number of system affected were quite wide. If lung involved, hemoptysis, hematuria. If bladder and kidney involved, proteinuria, bone pain, muscle pain, myalgias based on the muscle involvement, and skin involvement, cutaneous purpura. How we differentiate this type of vasculitis from PAN? All lesions are at the same stage, but they are distributed more widely. This spares medium and large vessels. This vessel vasculitis can be part of Schollen, purpura, and connective tissue disorders as well. So this can be part of any complexes. Now coming to other type of vasculitis, which is syndrome as well, Churg-Strauss syndrome. This involves small vessels. Sites are mostly lung and GIT and renal and heart. When sign and symptoms, I told you, it depends on the involvement as well. But in this part, as a part of complex, asthma can be there, allergic rhinitis, lung infiltrates, bilaterally peripheral eosinophilia. So these symptoms are part of this complex. Other signs, sign and symptom will be GI bleed, renal necrotizing lesion, heart cardiomyopathies, and eosinophilic infiltrates. Churg-Strauss syndrome, we can detect antibody, MPO ANCA in 50% of cases. This can come positive, and you can monitor the disease with and relapses with this as well. Morphology is similar to PAN and microscopic polyangiitis, but you need to add what? Add granuloma plus eosinophils. So whenever you are trying to memorize this type of vasculitis, try to put the morphology, because some things are similar. Some things are similar in different type of vasculitis, like for example granuloma, eosinophils, transmural, or segmental. So you can just write them up side by side. So that will make easier to memorize as well. Ricketts disease is a small to medium size vessel involvement is there. This is a triad. Triad means three things: recurrent of the oral aphthous ulcers, genital ulcer, and uveitis. These things plus there can also be involvement of GIT, pulmonary and neurological symptoms can be there. Another type of vasculitis is granulomatosis with polyangiitis. Previous name was Wagner's, which we all earlier discussed as the in the initial slides. This is also a triad. Triad of what? The necrotizing granuloma of upper respiratory tract or lower respiratory tract or both. So lung involvement is here. Necrotizing granulomatous vasculitis of the small vessels. Focal necrotizing involvement, often in form of crescentic granulomas. So this is a triad of these three things. Granulomatosis with polyangiitis pathogenesis is T-cell mediated hypersensitivity to normal innocuous inhaled microbial or even environmental antigen. PR3 ANCA positive in 95% of cases. So this is quite a lot. So you can monitor this with and you can in this you can find out the any exposure to inhaled microbes or environmental antigen. So you can based on this pathogenesis you can take the history as well. Now the signs and symptoms and sites of involvement may be restricted to either respiratory system or wide-spreading involvement of eye, skin, and organs, other organs. There will be persistent pneumonitis, bilateral nodular cavity infiltrate in the lungs if it's involving lung, oral mucosal ulceration, and renal disease can be there. Now, what's the morphology of granulomatosis with polyangiitis? Granulomas with geographical areas of necrosis. Geographical means like certain, as we see in the map, like islands, big islands type, with central necrosis and peripheral palisading of histiocytes, plus vasculitis and crescentic GN. Crescentic GN means crescentic glomerulonephritis. Now, before coming to the slides, let's recap a little bit. First, we covered the definition, then we covered the basic pathogenesis, basic hardcore facts about the vasculitis. Then we covered the types of vasculitis. We said that it's depend on the type of caliber of vessels, and classification can be large, medium, and small. And after that, I told you that vasculitis can be classified according to type of inflammation as well, like granulomatous, non-granulomatous. Similarly, there's another type section of vasculitis. This is a vasculitis associated with non-infectious disease, like in cases of autoimmune disease. We already discussed rheumatoid arthritis early, but this can be used as certain type of classification other than we have discovered which we have covered in the earlier slides. So don't get confused with that. This is non-infectious, based on the non-infectious causes. This classification: rheumatoid arthritis, systemic lupus erythematosus, Hanos-Schollin purpura, antiphospholipid syndrome, mixed cryoglobulinemia, and in malignancies, which we covered, the tumor markers or antigen in certain kind of vasculitis. So these are some of the main common examples in non-infectious disease. Now, there can be, if there's non-infectious, there can be infectious as well. Like infections, so infections can be any infection group, viral or bacterial, microbial, fungal. So how this infectious vasculitis reach? Either by direct inoculation in the vessel, localized tissue infection, for example, there abscess in the vicinity in the muscle, and secondary involvement of the vessels, or either can be hematogenous spread. For example, there is a sauce abscess or lung abscess or any other abscess, which is a site of main site of infection, and this is leading to secondary hematogenous spread of that organism with involvement of the vessels. Here we end the vasculitis. Now there's a certain types like Raynaud phenomena. These are different kind of phenomena associated with vessel hypersensitivity syndrome. First is Raynaud phenomena, exaggerated vasoconstriction of arterioles, especially fingers and toes. Rare sites can be peripheral sites like nose, earlobes, and toes. So this is exaggerated vasoconstriction of the mainly peripheral areas of the body. In the digits, we see first redness, white, and blue. So first redness causes vasodilation, and central area is white because of vasoconstriction, and there is cyanosis proximal to distal area, which is blue. Types, the phenomena can be primary and secondary. Primary is causes unknown, mostly seen in cold, emotional, extreme emotion, extremities, symmetric involvement, and this is remains static over time. Secondary Raynaud's is their causes are there like SLE, Burkitt's disease, scleroderma, atherosclerosis, extremities. What differentiates is the from other type primary type is that asymmetric involvement. This worsens over time because this is related to pathogenesis, and we have to evaluate for immune disorders as well because it's associated with immune disease. Myocardial vasospasm can be seen in cases of arterioles supplying the heart. This is not a type of vasculitis, but it's a hypersensitivity tumor, can lead to myocardial infarction, and causes can be intrinsic, hyperactive smooth muscle, increased vasoactive mediators either by cocaine, drug abusers, phenylephrine, by tumors, autoantibody to T cells and scleroderma, for example. Vasospasm of arteries, if sufficient, can lead to MI. So this is serious, and in sufficient spasm can lead to sudden cardiac death or ischemic dilatic cardiomyopathy as well. Here we wait for a while. I'm going to share you another slide. Now coming to our second topic is aneurysms. Aneurysm is defined as sorry, we have to change that. Coming to our topic. Aneurysms are defined as localized abnormal. This is a vasculitis topic has end, and now we are coming to section of our topic, which is aneurysms. Aneurysms are basically defined as localized abnormal dilatation of the blood vessels, or it can be vessels or rarely can be heart. So this phenomena is localized and abnormally dilated vessels is called aneurysms. So the causes can be congenital or acquired. True can be false. Congenital, acquired are self-explanatory, true and false. How we differentiate true and false? True is the type of aneurysm bound by all layers of the blood vessels wall. What were the layers of the blood vessel wall which are normal? These were intima, media, and adventitia, as we know by our knowledge of histology. while false aneurysm is a defect, just a defect in the vessel wall leading to extravascular hematoma formation. So you can just take the example of any tear in the heart or any tear in the vessel. So it will not be bound by all the layer of the blood vessel. As opposed to aneurysm, there is a dissection. In this, blood enters a defect in the arterial walls and tunnels in between its layers. So it's floating in between the layers of the vessel wall. Blood enters a defect in arterial walls and tunnels its between layers. Mostly dissections are also aneurysmal because they are also causing dilatation of the vessel wall. And another example can be classification can be based on the shape or shape of either secular or fusiform type. Secular is only one portion is descended while the other portion is longitudinal, while fusiform shape is both sides are distended similarly. What is the pathogenesis of aneurysm and dissection? Extracellular matrix, as we know, the vessel is strengthened by extracellular matrix like collagen, proteoglycans, and anything which degrades this or which cause deficiency or defective repair of this will lead to weakening of the vessel's wall. I take the example of connective tissues of the vessel is defected in cases of Marfan's, for example, of Marfan syndrome, Loeydert syndrome, Ehlers-Danlos syndrome. Marfan is defect in protein fibrillin. This protein defect leads to aberrant transforming beta growth factor beta activity and weakening of the elastic tissue in the aorta. Loeydert syndrome is there's a mutation of TGF transforming growth factor, and this leads to defective synthesis of elastin and collagens type 1 and 3. Ehlers-Danlos syndrome, defect in type 3 collagen. And these were the genetic syndromes with mutations, but there can be also defect caused during the vitamin C deficiency, which is called scurvy initially. But now this is rare because it's easily identifiable and corrected. So the balance is between pathogenesis is based on the balance. Either collagen is defectively formed, either collagen is excessively degraded, or synthesis is altered. So balance of collagen degradation synthesis is altered in cases of inflammation, and associated protease can lead to lysis of the vessel wall, or either increased matrix metalloprotein expression. What this expression does, especially in macrophages, as in atherosclerotic plaque or in vessels, MMP can degrade all components of ECM. So it can eat it up and degrade and causes weakening. So it's understandable if atheroma or plaque is heavily inflamed, it lead to unstable plaque and degrade it. Decreased expression of tissue inhibitor of micro proteases, TIMP, leads to increased degradation of ECM component. Examples are abdominal aortic aneurysms associated with increased expression of local protection of cytokines that stimulates the release of elastolytic MMP from macrophages. Vessel wall is weakened through loss of smooth muscle cells, either that phenomena or synthesis of non-collagenous or non-elastic ECM. In atherosclerosis, there is thickened vessel wall, therefore more oxygen distance to travel to the tissue. More traveling means less oxygen reach, degeneration of the smooth muscle cells, and change in phenotype ground substance to amorphous pink substance called cystic medial degeneration. Example is obliterative and arthritis. Small vessels, especially involved, lead to ischemia and aneurysmal dilatation of aorta, which were seen in cases of tertiary syphilis. Now, aneurysms can be classified based on the size as well, fusiform and secular, and another type is based on the site, abdominal aortic aneurysm. Most common site is abdominal aorta, and iliac arteries. Most frequently seen in men in smokers. Rare is before 50 years, and its major risk factor is atherosclerosis. Morphology: usual site is below the renal arteries and above the bifurcation of aorta. Can occasionally affect renal or superior inferior mesenteric arteries either by direct extension or by occluding the vessel ostia with mural thrombi. There are three subtypes of abdominal aortic aneurysm: inflammatory Ig4 related aneurysm and mycotic. Inflammatory typically occurs in young, back pain, increased CRP, C-reactive protein, and in this there is abundant inflammation of lymphoplasmacytic type. There can be giant cells. This can also extend to retroperitoneum. Ig4 related aneurysm: high plasma level of Ig4 and tissue fibrosis. This disease is named based of IgG4 elevation. Frequent infiltration of IgG4 expressing cells may affect variety of tissues. MYCOTIC is as the name indicates, by microorganism. Clinical feature based on the site: abdominal mass may be pulsating. When we palpate, it may rupture into abdomen, iliac arteries, impingement, embolism from the atheroma. Thoracic aneurysm: most frequently associated most frequently association is hypertension, Marfan syndrome, Lloyd syndrome. Sign and symptoms based on the thoracic, as it's involving thoracic, the sign symptom related to thoracic area: respiratory dyspnea, esophagus dysphagia, recurrent laryngeal nerve involvement will be hoarseness, bone erosion by compression on the rib cage, and vertebra. Cardiac disease can be there. When tear inside the aorta cause blood to flow between the layer of now coming to aortic dissection, which is a very serious disease, needs most urgent attention, mostly seen in 40 to 60 age. Hypertension, especially uncontrolled young age, can be seen also. In cases of connective tissue abnormalities, example is Marfan syndrome. Other causes of aortic dissection are iatrogenic, for example, by doing coroning artery bypass in pregnancy, third trimester, or after delivery. This can also be seen because of altered hormone, and this lead to relaxation of the smooth muscle cells in the vessels. Rarely in cases of atherosclerotic or scar tissues, like for example syphilis. Now dissection can be two types. Proximal one type involves either or both ascending or descending aorta. Type 2, distal not involving ascending part, usually distal to subclavian artery. Morphology: cystic medial rendition, like amorphous pinkish substance deposit infiltration. This can result in radiology showing double barrel aorta, or if chronic dissection occurs and it's healed and not ruptured, this can lead to chronic dissection. So this is one of the medical emergency aortic dissections, and we need to correct it as soon as possible. And this dissections tear is also related to their size as well, in addition to the cause behind it. So we need to correct this as soon as possible. Here we end our lecture. I hope you understand all the things, all the topics. So just a little recommendation from me is that in vessels, vasculitis, try to memorize logically all the things, and try to classify them according to different types as well. So you will learn it more easily. Thank you, everyone. Here we end our session. Allah Hafiz.
Ma'am, should we end the lecture? Should we end this meeting?
I think so. I have covered all the topics.
Okay.
Yes.
Thank you, ma'am.
Thank you.